experience of 18 to 19 years and book author of 3 books. So bache, let us start. I'm just checking if everything is working fine on YouTube or not. Guys, just give us a second. Sir, is it coming on YouTube?
Yes, it is.
You are able to see it?
Yeah,
Okay. Okay, there was some error on my side, I guess. It was not coming
there's a
in my.
lag actually. There's a lag.
Okay, okay. So, sir, let us start with our session then.
Yeah,
Okay, okay. So, in this session, bache, everybody will be discussing the global guidelines for the diagnosis and management of mucormycosis. This is, bache, these are the latest set of guidelines. These are the absolute latest set of guidelines which were published in Lancet. Lancet is one of the most prestigious medical journals worldwide. So before we even go further, I am very curious about the fact that what is the need of the session? Why is so much of this? Why is so much of stress being, so much of emphasis being laid on mucormycosis? But mucormycosis, it is a rapidly progressive disease. The lesions, they are destructive in nature, and delay in therapy, if the clinician is not able to diagnose the disease early, or any delay in therapy, is associated with a very high mortality of 40 to 70%. Now, Sanjay sir, do you see such a high mortality rate in any other disease associated or infection or something?
Dr. Sushant, in the head and neck region, there is no other infection with such a high mortality.
Mortality.
Whether it is fungal or bacterial or viral, there is no other infection with such a high mortality rate.
So,
And that's what makes this disease such a devastating disease.
true. So I guess that is why even as students, because your relatives, people will be calling you, they will be telling you few symptoms or whatever, and the incidence of mucormycosis is rising rapidly, also called as black fungus. We will see why it is black fungus, but the incidence are rising rapidly. So you need to diagnose the disease firstly. Secondly, we need to be, I guess, more informed as compared to the patient also, because patient these days, they are also seeing all the Google and seeing the diseases and stuff. So agar kisi some patient might also send you this ki I have developed black fungus, so see me, immediately, but it was not black fungus. So obviously we will not go by the what the patient is googling.
I'll tell you an incident here.
Yes, sir.
I have a patient, young, he's diagnosed as mucormycosis, and he doesn't want to get surgery done. It's not related to COVID. It's been there for some time now.
Okay.
And suddenly he reads about this mucormycosis in a paper, and he calls me up, sir, मेरे को आज ही आप surgery करो."
Okay, I said it is. I guess Google and media is a double-edged sword. Wo sometimes they motivate the patients and whatever. But anyways, so starting with our main academic session. This is where I guess we start with the serious content. But everybody, all of you who are viewing the session, I know pretty straightforward question. Main causative organism for the development of mucormycosis is ABCD. I want all of you to tell me the answer in this. You're sitting in the exam. This is a session not only for MCQs but also as a doctor. But I'm very curious. If I was in your place and I had not known about this, I would have gone for mucor species. But nahi bache. Agreed. It is Rhizopus. Main causative organism for the development of mucormycosis is Rhizopus. All four are the etiologies. It is associated with rhizopus, mucor, leishthemia as well as rhizomucor. All four are the etiologies, but the most frequent causative organism for mucormycosis is rhizopus species. It is a fungal organism belonging to the order Mucorales, and these are the other species associated. Sir, any? Hmm.
Yeah, two things. One is because you look at the second name, mucor, and it matches with the name of the disease, mucormycosis, and therefore students might get confused because the disease called mucormycosis, they may think that by default mucor must be the most common pathogen. It is not.
It is not.
Rhizopus is the most common.
True.
And the third one, leishthemia, this is not seen in India so far. This has been only found in Spain.
True.
And has not been found in any other country.
Except.
And that's why from the India point of view, it may not be that important.
As
but
of
you have
now.
to know that it's one of the pathogens.
True. As of now, and hopefully, I mean, the last time we did this session on the mutant, sir, we said that UK variant and South African variant is not present in India as of now. So, but totally.
But fungus don't mutate. Fungus don't mutate. Viruses that mutate.
True. Agreed. Totally agreed, sir. Next. So, coming to the clinical.
Clinical presentation, guys. It's at the end of the day, it's an infection of we are only dealing with the mucormycosis of the nose and the sinuses, going on to the orbit and the cranial cavities. So essentially, it's a sinusitis, and therefore most of the symptoms are of those of sinusitis. So we might get tricked that thinking it's a simple sinusitis. So the high suspicion index of suspicion should be any person who have had COVID in the recent times, or somebody who's diabetic, monocontrolled or uncontrolled, and somebody who's on corticosteroid therapy. In these patients, even if you have a symptoms of simple sinusitis like nasal blockade, look at the first one, nasal blockade, nasal discharge, simple things, still you have to suspect a mucormycosis. Because as we have seen, the mortality is, if you delay the treatment, is more than 40%, which is huge. And that's why don't get tricked thinking that it's a simple sinusitis. So nasal blockade and headache and pain in the eye, these are some of the common symptoms, most common symptoms. But because mucormycosis is a necrotizing disease of the nose, it causes necrosis, we'll know why. And that's why it's called the black disease also, black fungus. And that's why they are black discharge, black thin discharge. And the skin around the eye and the nose and the cheek might get necrosed and look black. We'll show you images. Dr. Sushant will show you some images.
We'll see that.
And if you do endoscopic examination of the nose, you can see black turbinates, black tissue, and all that. So these are very profound findings, which straightway tells you that it is mucormycosis.
True.
Not only this, besides this, the one that has spread to the orbit and the cheek, you'll see some swelling in the orbit, around the orbit, on the cheek, some redness and pain and tenderness at times. And when it goes down, you know, what is the floor of the maxilla, floor of the nose? Floor of the maxilla is alveolus, and alveolus is stiff, and the hard palate. So there is toothache, loosening of tooth when it goes downwards. So it depends on which direction it's flowing. This is easier. See, if the infection goes downwards from the sinuses, from the maxilla downwards, at most what? You go to the oral cavity, hard palate, loosening of tooth might come out, not dangerous, can be tackled. But the ones which are dangerous are the ones that are going upwards or backwards, orbit, cranial cavity. And that's why we have this term called orbito-rhino-cerebral mucormycosis, which goes from the nose to the orbit to the sinus. And these are the fatal ones. And these are the ones that we have to be careful about. And other things like, if it goes to the orbit, obviously there will be ophthalmoplegia, and there's double vision, which is called diplopia. And these are the important presentations of mucormycosis. Now, Dr. Sushant will show you some images with these kind of findings.
The images actually are pretty scary, because it can start as a very mild disease, like as we saw in the first patient. And actually, sir, all these images they were seen in COVID positive patients. Now in the first lesion, the first patient, there was erythematous skin, ptosis, ptosis, palpebral edema with limited ocular mobility and right maxillary pain. So the first message that the student should take home from this slide is, even the milder symptoms of nasal blockage or sinusitis, as you very rightly said, sir, headache and pain in the eye, should not be overlooked in current era. The second case showed a patient of proptosis with palpable erythema developing 7 days after symptom onset in uncontrolled diabetes. We will have a look at all the high risk category patients that as sir told us, that diabetes, uncontrolled diabetes, patient on steroids, patient needing ventilation. We'll make a list of the same. Next, the third case, the third patient, as bache again you are able to see here, shows necrotic or purulent palatal ulcer. This is the necrotic purulent palatal ulcer along with presenting with cavernous sinus syndrome 8 days after symptom onset in uncontrolled diabetes. Next, again, a child. I know I was very dicey whether I should put this image for the students or not. But in the end, this is the severity of the disease, which is rhinocerebral mucormycosis. As the infection goes upwards, the mortality is much higher. Rhinocerebral mucormycosis in a female child who was 2 years old and was a case of ALL, acute lymphoblastic leukemia, unfortunately had a lethal outcome, and an elderly with persistent neutropenia post chemotherapy. We will again see as we'll go further in the session, but here we will see that neutropenia is again a risk factor for development of mucormycosis. We'll be having a look at all these. So these are the main clinical presentations. This is how the patient manifests in a case of mucormycosis. Now, what is the route of infection? But in an immunocompromised individual, it occurs obviously by the inhalation of sporantiospores. In diabetic patients, rhino-orbital disease is more common. Now, when we talk of mucormycosis, do not limit yourself to the thought process that it will be associated only in uncontrolled diabetes or on patients with steroids. Now, of course, this is the definition of the high risk group. That is patient of uncontrolled diabetes with diabetic ketoacidosis on insulin, all those who have received corticosteroids along with immunomodulators and require oxygen delivery systems. These are the high risk categories. So if I have to enumerate them, this is a slide which is of course important for the MCQs. You can get a question like all of the following are the high risk categories or all of the following are associated with high risk of mucormycosis except or something like that. Uncontrolled diabetes and immunocompromised everybody knows. But in neutropenics, please put a star. Very, very important. I want you guys to tell me this. Which is the main peripheral smear finding in a case of COVID-19? What happens to leukocytes? What happens to leukocytes in COVID-19 disease in peripheral smear? Which leukocyte predominantly reduces? Bache lymphocyte. COVID-19 disease predominantly on peripheral smear is associated with lymphopenia. Lymphocytes reduce in number. That is why when we discussed COVID-19 in detail, we saw that it is associated with increased NLR, increased neutrophil to lymphocyte ratio. Lymphocytes are reducing, the denominator is reducing, so neutrophil to lymphocyte ratio, NLR ratio, neutrophil to lymphocyte ratio increases, which was again a poor prognostic marker. But patients in whom there is associated neutropenia also, totally agreed, everybody was right with respect to lymphopenia, bache. Now patients in whom there is associated neutropenia also, neutrophils are also reducing, they are at an increased risk of infection by mucormycosis. Next, high cytokine levels of interleukin 6, high ferritin. Why? What is the role of ferritin? What is ferritin? Which it is the storage form of iron. Ferritin, it is the storage form. It is the storage form of iron, and mucor feeds on free iron. As a result of which, patients with high ferritin are a high risk category. Those with a high CT score who needed ventilation or tocilizumab or hydrosteroids, these are the high risk category patients for the development of mucormycosis. Sir, absolutely anything to be added in the high risk category?
Not to be added, the list is comprehensive, but look at the last point, where it says that all these patients, they should undergo weekly endoscopic examination. And the idea is to detect the disease at a very early stage because it's a very dangerous disease. So if you can detect very early, then the outcome is much better. But once it goes beyond the realm of the nose and the sinuses, then this is where the fatality starts increasing. So long as the disease is confined to the nasal cavity and the sinuses, it is manageable with medicines, with surgery. And like I said, the moment it crosses these boundaries, this is where it tends to go to the orbit. Orbit still can be managed. You lose the eye maybe, but you still manage to save the patient. Once it crosses the cranial cavity into the brain, this is where hugely you remove 40 to 70%.
True.
In fact, if once it goes to the cranial cavity, there's almost 100% fatality, almost nearly 100%. Nobody survived. Nobody has survived so far. Anybody who had proper cranial extension, and that's why this endoscopic examination. Because see, it sounds very easy to say weekly endoscopy, but think about this: is it practical? Especially in today's time where hospitals are full, we are overwhelmed with the patients, it's not practical. So what we do is we don't do endoscopy so much because see, once the endoscope goes in the nasal cavity, it might get infected with COVID and mucor, and without sterilizing the thing, you can't put in another patient, you can't use it on the patient. And that process of sterilization takes some time. So there's a limitation of this. And so what we do instead is we just do a simple NTA rhinoscope. Suppose a patient comes to me today, okay, with this high risk, and I do a proper endoscopy, and I see everything is normal. If the patient comes next week, I don't have to now go for endoscopy. I can do a simple rhinoscopy because I already know what to look for. So it saves a lot of effort from our part, and also a lot of money to the patient and a lot of trauma the patient goes through. And endoscopy is not a very easy procedure, not difficult, but not a very simple procedure. So this is more of theory, that weekly endoscopy. In India, practically, these are Western guidelines. In India, you cannot do endoscopy every week on a patient. There are a lot of logistic problems.
True.
But yeah, you have to examine the patient every week properly. Follow-up has to be there. That's what it means.
Sir, the figures that you said were actually giving me goosebumps, and they are scary. I mean, it is all jokes apart. It is
and that's why we are discussing this today.
Yes.
That's why we are discussing.
True. Next, now it is a disease not only limited to the high risk category patients, in the sense that even immunocompetent patients, immunocompetent individuals, they are associated with the development of cutaneous and the soft tissue mucormycosis. It usually occurs after skin disruption and is clinically. Now have a look at this. This is the primary cutaneous mucormycosis of the left leg. All this is the black fungus. It is the black fungus cutaneous mucormycosis of the left leg. So seen usually after skin disruption. It can be after road traffic accident, any injury to the leg, any surgery, burns, anything like that, and clinically presenting with abscess, skin swelling along with necrosis and eschar formation. So mucormycosis is not a disease limited only to the diabetics or the patient on steroids, but is also seen in immunocompetent individuals. Coming on to the pathogenesis of the disease, two main categories of high risk patients: diabetics and those who have taken steroids. Why are the chances of development of mucormycosis much higher in these two categories? Diabetics, they are associated with hyperglycemia. This in turn causes neutrophil dysfunction, reducing the chemotaxis and reduced intracellular killing. That is, in a diabetic overall is associated with reduced immunity. Diabetic ketoacidosis in particular is much higher risk category. This is because in a patient of diabetic ketoacidosis, more free iron is available in serum, and as we already saw it, that mucor takes up this free iron and becomes more virulent. That was why we saw that increased levels of serum ferritin are a risk factor for development of mucormycosis. Next, steroids, again they decrease immunity, cause hyperglycemia, as well as we have a steroid induced mucormycosis. So this was the pathogenesis. So
Sushant, on the last slide, I want to say something, add something. Yeah. The fact that people with high free iron are susceptible or high risk patients. Two things. One is this nickel, it feeds on iron to not only become more virulent as is shown in the slide, they also need this. These are like the essential ingredient for them to survive, to grow, and to propagate. So there are two things. They survive on that, on free iron, and they also become more virulent. So the two things here. That's why people with free iron, they're high risk patient, and that's why ketoacidosis are the ones who are very, very high risk patients. This is one point.
True.
And then we go to the next slide. Now, why is mucormycosis? All this is fine, that people who are high risk, diabetes, people with steroid therapy, these are the patients who get this infection. They get infected by mucormycosis. But why is this disease such a dangerous disease? Why is the mortality rate is such a high? Is essentially because of this angio-invasive nature. If you look at the first line, it says mucormycosis angio-invasive. Now, students, please get this word angio-invasive into your memory, into your brain, ingrain this into your brains, because this is the most important word so far that we have. Most important word about this disease is the fact that it is angio-invasive fungus, the only angio-invasive fungus in the head and neck region. And this property of the fungus, the fact that it is angio-invasive, makes the disease such a dangerous disease. Now, what happens as a result? Two things. One, it mainly goes into arterioles and through that into the capillaries, and it often blocks the capillaries. Now, you understand, if the vessel is blocked, what will happen? The blood supply is cut off, and that causes ischemia, and if the ischemia is prolonged, and that causes necrosis, and the whole tissue becomes necrosed, and this is why the tissue becomes black, and the name black fungus comes from here. This is the reason why it's called black fungus. And therefore, if they ask you which of the following is a necrotizing disease of the nose, or necrotizing fungal disease of the nose, this is the necrotizing fungal disease of the nose. There are two important necrotizing diseases in ENT, one in the ear, one in the nose. In the nose, this is mucormycosis. In ear, it is malignant otitis externa. And both are seen in diabetic. Both are seen due to immunocompromised status. But malignant otitis externa is essentially seen in elderly diabetics, as we see. That's okay. But this one is a young diabetic. That's the huge thing. If you read your books, they'll say mucormycosis disease of young diabetics. So it infects a lot of young people. And necrosis of the nasal tissue, that's why there's a nasal discharge, black color nasal discharge. I told you under endoscopy you can see black turbinates, black septum, black tissue, black sinuses. And when it goes to the orbit, that's why if you remember those, the periorbital skin and the skin of the cheek and all have become black because of necrosis. So a diabetic with black nasal discharge, the first thing that comes to your mind is mucormycosis. The only thing that comes to your mind now is mucormycosis. Any diabetic, uncontrolled diabetic especially, with black nasal discharge, the first thing is mucormycosis. Now the second thing that happens, first is that of course it blocks the vessels and therefore necrosis. And the second thing is, it's when it invades the blood vessel, it mixes with the blood and then spreads with the blood. If you read the word, it spreads very fast. See, normally when any disease spreads from any side, it spreads from tissue to tissue. From one tissue, it will go to the next tissue and the next tissue and the next tissue. You know, we call it a direct spread from tissue to tissue to tissue. Now, this kind of spread is usually relatively a slow spread. A direct spread cannot jump. From the nose, it cannot jump directly to the orbit or to the cranial cavity. So it gives you a lot of time to diagnose and treat and take care of the patient before it is too late. But here, look at this situation. It invades the blood vessels, as I said, arterioles, mixes with the blood, and through the blood, it spreads to any part of the body within minutes. Within minutes, it will go right from the nose to any part of the body. You understand this, right? And the nearest serious areas, one is orbit and one is cranial cavity. See, orbit is surrounded by sinuses from almost all the sides. Look at the eye. Above the orbit is the frontal sinus, medial is the ethmoidal sinus, below is the maxilla, and just behind is the sphenoid. Except the lateral wall, orbit is surrounded by sinuses from all the sides. And therefore, any sinus which is infected with mucormycosis, orbital spread and orbital complications are pretty common. And most of the sinuses, the roof of the ethmoid, roof of the sphenoid, roof of the frontal sinus, they are all formed by skull base. So once this infection crosses the roof of any of these sinuses, it lands into the cranial cavity, causing cranial symptoms. That's why there are two terms. One is we call it rhinocerebral mucormycosis. It's a very commonly used term, rhinocerebral, from nose to the brain, and rhino-orbital mucormycosis, from nose to the orbit. And when it involves all of them, like we are using this term, orbito-rhinocerebral mucormycosis, so it can go from the nose to the orbit to the cranial cavity. Now we'll come to the treatment part a little later, but I just want to highlight one point. One of the things that we do in this surgery is that we debride the area tissue that is involved. So if I say debridement of the nasal tissue, nasal terminate sinus, that doesn't sound very bad. Okay, it's done once in a while. But think about debriding the orbit or debriding the cranial cavity. These are huge implications, isn't it? And that's why we have to be very, very careful about this disease, and we have to diagnose the disease at a very, very early stage. So this angio-invasive nature, keep this in mind, is what makes this disease a dangerous disease, a tumor-like disease, a fatal disease. Right?
Honest.
So this is another guideline in a way that how should you approach this patient of mucormycosis. And if you see at the top table, these boxes, there are conditions where there is a neutropenia. How do you know neutropenia? There's persistent fever and respiratory symptoms. In these patients, what do? You get a chest CT scan. And what is the typical finding? Dr. Sushant will talk about this yellow sign, more than 10 nodules and all that.
True, we will discuss that, sir.
And, yeah, we'll discuss that. Then diabetic. How do you know diabetic? What are the symptoms? Pain, facial pain, sinusitis, proptosis. And in these cases, we have to go for cranial CT scan because cranial spread is very, very fast because these patients are usually highly immunocompromised and you'll see a lot of bone destruction. That's why it goes to the cranial cavity. And patients who have a trauma, these patients have persistent fever and they have respiratory symptoms also. Again, you have to get a CT scan done in these patients. And then, especially in Asian countries, in India, China, and all these countries, you have to get ultrasound of the abdomen and the CT scan of the abdomen, where you look for enlarged kidney, basically. And you can see this hypodense cortical rim signs and all these things. And for staging of this tumor, of this infection, you're talking about staging and a lot of scoring and all that. So everybody knows that we go for CT scan of the chest, mainly, predominantly chest. There's scoring and staging. And also you can do the CT scan of the sinuses and the abdomen, which helps you in staging. Right.
Sir, we had a query with respect to HSCT, but HSCT, hematopoietic stem cell transplant. We'll be discussing that when hematopoietic stem cell transplant occurs. So again, it is bone marrow transplant or hematopoietic stem cell transplant. The patient is in an immunosuppressed state. Neutropenia or HSCT is again a risk factor for mucormycosis. Now, as sir told about this, that we did the staging. Now comes the role of the pathologist. That is the sampling. We do a biopsy. Biopsy can be endoscopic or CT guided biopsy. This biopsy is visualized either by microscopy using the fluorescent brightener or histopathology. You very well know the histopath stains for fungal diseases. That is PAS, periodic acid shift, Brocaud's methenamine silver stain, in which we see the typical non-septate ribbon-like hyphae, 6 to 16 micrometers wide, along with vessel occlusion. To vessel occlusion, as sir had emphasized, vessel occlusion, a very, very important direct microscopic feature also. On culture, we see the typical findings of cottony white or grayish black colonies, after which a susceptibility testing is performed. So let us now have a look at the radiological and lab findings associated with mucormycosis. Now, sir, before we go further, sir, will you like to take this question? Gramel, do you see such cases will go up in nearby future because of rampant use of steroids?
Yeah. In fact, when we were showing those images of patients with periorbital swelling and those black patches on the skin, I just wanted to say then, but I missed that point, that now post-COVID, we are seeing these kind of pictures very, very common. Yeah, first, these pictures are very, very common. I'll tell you some facts. See, as an ENT specialist and practitioner in Delhi, maybe I would see 3 to 4 cases of mucormycosis per annum in 1 year. And now in the last 2 months, I've seen 8 to 9 patients of mucormycosis just in 2 months. So think about the difference in the percentage increase. 3 to 4 patients per year versus 10, almost 10 cases in 2 months. And many of these patients come with these kind of figures, these images that you see. These are very, very real images. These are happening every day in the ENT operation now, every day. Of course, can you see the next slide? Next one. Yeah, these pictures are not common. These are extreme cases. I've not seen this kind of rapid spread, especially the cutaneous one. But the last slide that I showed, which is very, very common, and it is already increasing. And most of us are overwhelmed with the surgery. We cannot, people line up for surgery. We have waiting list of surgery for these cases now, that we cannot do more than 2 or 3 surgeries per day. And you can think that patients have to wait for 3 or 4 days. And that's why the role of antifungal becomes very important, because we cannot do 10 surgeries per day, or, so patients are on waiting list. And one of the things that we do, not we, but ophthalmologists do, is we have to remove the orbital exenteration. Now, I have come across ophthalmologists who say, in my entire 10 years or 20 years of career, I've done just 2 exenteration of the orbit. In the last 2 months, I've already done 5 exenteration of the orbit. Can you imagine?
It is actually
entire career 2 versus 5 already done in this year, this 1 year. So that's the volume, that's the figure, and this is what we are looking at in future.
Sir, actually, rampant use of steroids is majorly to blame, I guess, because if I go to a chemist today and I just want to purchase a steroid or something, it will not be available in the market. I mean, people have taken them off big time. But
we'll talk about this aspect when we talk about the treatment part. I'll highlight a bit about that.
Agreed, sir. So this gets us to the radiological findings. What do we see radiologically in a case of mucormycosis? Which are 2 main signs radiologically. First is halo sign. In halo sign, have a look at the site which has been marked with the arrow. But there is a ring of ground glass opacity. This is the ground glass opacity, a ring of the same surrounding a nodular infiltrate. Why are we seeing the halo sign? If we correlate it pathologically, this is because it represents the area of ischemia. Halo sign. At MBBS level, diagnosing a halo sign is slightly tougher as compared to reverse halo sign. Reverse halo sign, this is the classical image of the same. Have a look at both the images. Let me keep it like this here. Have a look at both the images. Reverse halo sign, it is also called as atoll sign. Reverse halo or the atoll sign, in which there is an area of ground glass opacity surrounded by a ring of consolidation. So same thing you are seeing in the second image also. There is an area of ground glass opacity which is surrounded by a ring of consolidation. This is called as the reversed halo sign. So radiologically, we see 2 signs, halo sign and the reverse halo sign. Next point, coming on to the microscopy of the same. Mucormycosis, it typically has a hyphal morphology. It is associated with typical hyphal morphology, in which the hyphae, they are 6 to 16 micrometers wide. बहुत ज़्यादा wide नहीं है. देखो, be unbiased. When you have a look at this image, you can confuse it with aspergillus also, thinking of it as branching hyphae. But no, these are pauciseptate and they branch irregularly. I have deliberately said that we can confuse it with aspergillosis. Compare this slide with aspergillosis. I'll show you the 2 again together. This is the classical acute angle branching. This is the classical acute angle branching that we see in aspergillosis. Firstly, next, they were 3 to 5 micrometers wide, regularly septate with dichotomatous branching. Versus mucor, which was 6 to 16 micrometers wide, branch irregularly and was pauciseptate in nature. Next point, YouTube, I'm actually It's sad to hear that your father was given amphotericin and CMV lung, because CMV cytomegalovirus is an opportunistic infection, no doubt about it. Next, sir, will you like to take Kranti's question? Can we see this in the patients taking MDI, budesonide, or fluticasone nasal drops?
Actually, yeah. Any Usually these are taken locally in the form of spray, and because they particulate in the nasal cavities, the steroid particles, and so you can have, although less commonly, but because we take in the form of spray, and the spray is usually taken from the nasal cavity, maybe mouth also, and therefore they can settle there and decrease the local immunity, and so the chances of mucormycosis is still there. Not as much as in a systemic in the form of tablets, but yeah, it is always there.
Okay. Next, now, bache, before we go on to our next part in microscopy, I'll just like to say that firstly, this in our first part of mucormycosis session, just as a quick recap, we saw the clinical features of mucormycosis, had a look at the various presentations, rhinocerebral or the rhino-orbital disease, the various presentations, radiological and microscopic features of the same. In microscopy, we differentiated mucormycosis from aspergillosis. Firstly, secondly, which microscopically, I'll go to the fact in just 10 seconds, that there can be the presence of acute lesions. If it is acute in nature, we'll see the presence of hemorrhagic infarction, necrosis, and angio-invasion. I cannot even stress angio-invasion more. Angio-invasion with neutrophilic infiltration and perineural invasion. So in acute lesion, the disease is spreading in nature. Versus, so there was hemorrhage, necrosis, angio-invasion, and perineural invasion. Versus chronic cases, which is associated with pyogranulomatous inflammation. There is pus formation, pyogranulomatous along with granulomas, and the presence of giant cells, and the hyphae are covered by splendor Hople phenomena. A very important prospective question, especially for the exam going students. But the hyphae is covered by splendor Hople phenomena. What do we mean by splendor Hople phenomena? These are the deeply eosinophilic material which surround the hyphae. The hyphae, they are surrounded by eosinophilic material called as the splendor Hople phenomena. This is seen in chronic lesions. So, bache, in our first session or in our first part of mucormycosis, these are the main or the salient features that we discussed. Next point. Now I am saying this as the first part, as in the second part of this session, in the second part, bache, we will go towards the therapy and the management of the same. This is because of the technical time constraints, bache, we can keep the first session as only 40 minutes. So we will be continuing in this session, and in case the session breaks, I am saying so that in case the session breaks, the second session we will be starting it at a gap of 2 minutes. You will be having the link on YouTube on the Unacademy platform only, and we'll be starting the second session after a break of 2 minutes. Next, now, sir, before we do that, sir, will you like to take these two questions, Shri Tej and Sunita?
The first one, which says that oxygen support, moisture, and all that. This I will discuss when I talk about the preventive measures, or what are the factors that can induce in COVID. So, and the second about Sanyukta, I'm surprised to know that your dad is taking prednisolone eye drops for 3 continuous years. Although I'm not an ophthalmologist, but I find it very strange. Please, are you checking with your ophthalmologist regularly? Because 3 years continuous prednisolone eye drops, it's a very, very dangerous situation. I don't think of any situation, at least I don't know when it is used. Maybe, I'm sure that you are checking with your ophthalmologist very, very carefully. But when you put any drop in the eye, it trickles down to the nasolacrimal duct into the nasal cavity, isn't it? And then from there it goes to the nasopharynx, and then it goes down. And therefore, any steroid, corticosteroid in any form is a risk factor. Some may be more, some may be less, but they are all risk factors. So, but these are common drugs. If a person who's on steroid, if they are not known diabetic or they are not exposed to COVID, they have not had COVID, then it's relatively safe. We are talking about people who are diabetic and have COVID, or COVID and they are taking a lot of steroids, systemic steroids especially. We are dealing with those people.
High dose
But
systemic.
any patient with any steroid in any form has a potential to get this infection.
True. Next, so Bache, this, as we discussed it pleasantly, actually this time the link did not break after 40 minutes, sir. So I guess even the link recognizes the importance of the session, I guess. So microscopically we saw two lesions, acute lesions which had hemorrhage, necrosis, angio-invasion along with perineural invasion, versus chronic lesions. Chronic, so it is associated with pus with granulomas, pyogranulomatous inflammation. Granuloma के साथ giant cells are also seen, and the presence of Splendor-Hopeley phenomena. Splendor-Hopeley phenomena, in that we see deeply eosinophilic material which is surrounding the hyphae. This was the microscopy, and we have already differentiated a case of mucormycosis from aspergillosis. So
now the bottom, this is the crux of it.
This is the crux.
Once we made a diagnosis, what to do about it. Right? Now we all know that in a diabetic patient with mucormycosis, now somebody was asking, is there a bedside treatment method of diagnosing? Bedside means you have to have a very high suspicion, index of suspicion basically. If a person is COVID positive, patient is on steroid, patient is diabetic, controlled or uncontrolled, if this person begins to have any sinusitis symptom, simple sinusitis, nasal blockage, nasal discharge, pain in the nose, headache, the first thing now at this point in time that should come to your mind, it could be a mucormycosis. So by looking at the nose or the mouth in the initial stages, at least you cannot make out, because things are deep into the nose, right? One of my Mossy, she has COVID in Raipur, and she started having pain in the nose and slightly reddish skin over the nose, and she went to a GP. She was on COVID treatment, and straight away says it is mucormycosis, and talk to an ENT specialist. And that's when she called me up from Raipur, and I said, no, mucormycosis in the initial stages, if I'm looking out from outside, you cannot make out. Straight away, you cannot have a skin lesion, redness on the skin and pain on the nose. There has to be other sinusitis symptoms like discharge, blockade, and as it says, pain around the face, and sinusitis, and only when it goes to the orbit, it will cause proptosis, when it goes to the orbital cavity, and it involves the muscles of the orbit, it will cause ophthalmoplegia, that may cause diplopia, which is called double vision. Right? In this, as we have discussed already, CT scan as well as MRI, both are important. Why? Two. Now, CT scan will show you the bony breach. You have to see the bones, and that's better seen on CT scan. But orbit is full of soft tissue. There are a lot of muscles. It's predominantly fat, a lot of muscles, and there are vessels like there's a thyroid artery, ophthalmic artery, and there's a nerve, ophthalmic nerve, optic nerve. Sorry. So these things you can only see on an MRI, and the MRI is not a plain MRI; it's a gadolinium enhanced MRI. Now, what happens is, as we've discussed, that it's an angio-invasive fungus, and therefore it has a tendency to block the blood vessels, and therefore it causes ischemia, necrosis, and therefore it's called the black fungus. Now, once it blocks the vessels, the blood supply is cut off, and therefore if you give a gadolinium, so the lesion will not be enhanced on an MRI. You can't see enhanced lesion, and this is one of very important diagnostic finding in these patients. So MRI is of a profound importance in these patients. Same is for sinusitis. For sinusitis, as I told you earlier, that you have to do endoscopic examination, plus, it's not mentioned here, plus you have to do MRI here also, and also CT scan, all the three. MRI is better than CT scan if you have to go for one. If you can go for both, that's the best thing. Now, why endoscopy? Because it will show you the nasal tissue, it will show you the turbinates, it will show you if there is any black patch, any mucormycosis tissue. Once you have a look at the tissue, even twice on endoscopy, easily third time when the patient comes, just the look of the tissue you can make out it is mucormycosis. And CT scan again, because a lot of breach on the sinus walls are seen. So whether the sinus wall is breached or not, is it intact or not, is the wall between the nose and the orbit breached, like lamina papricia is a very thin bone, sometimes breaches, and through that the infection goes into the orbit. So you can see the bony margins, if they are intact or not. If the bony margins are not intact, means the infection has gone through the bone. But the most important thing is what I'm coming to is MRI. As I said, gadolinium enhanced MRI. Now you do T1, T2 weighted images, and they give us a lot of information. CT scan will show you the sinuses, nasal cavity very nice, no problem. But when it comes to the peri-sinus area, or as you call it, peri-antral area, just behind the maxilla. You know what lies behind the maxilla? Behind the maxilla, there are two important fossas. One is called pterygopalatine fossa, and one is called infratemporal fossa. Now, and these areas are full of soft tissue once again. And between this soft tissue of these two fossas, pterygopalatine fossa and the infratemporal fossa, and the posterior wall of the maxilla, there is a gap. There is a slight gap, and that gap can be seen on an MRI. But if this infection breaches this area and goes from the maxilla, behind the maxilla to this area, these fossas, then this gap cannot be seen. And it is not enhancing as well, as I said, because the blood vessels are blocked. There's a very important artery called sphenoplatin artery that gets completely blocked and sclerosed actually. The blood supply is cut off. So to see this involvement, the peri-sinus involvement, is paramount important, because and you can only see this on MRI, otherwise you can't see this. And that's why in sinusitis along with endoscopy, MRI is of paramount importance. Why? Because when you're ultimately going to do a surgery, and suppose you don't know this fact, that behind the maxilla also there is an infection, and once you clear the nasal cavity and you clear the sinuses, and you can see the bony walls are intact and the tissue is now normal, endoscopic look will not tell you that there is something behind these walls of the maxilla or behind the walls of the nose. And if you know through MRI prehand, then you can remove these walls and go behind the maxilla and remove the disease from there. Otherwise, the whole effort that you have done, the big surgery that you have done with endoscope of the sinuses and the nose, is a waste of time. It's a futile surgery, because from those fossas, pterygopalatine fossa and the infratemporal fossa, this disease is bound to go to the cranial cavity. You know that in infratemporal fossa and the cranial cavity is connected with via the foramen ovale, and pterygopalatine fossa and the cranial cavity are connected with foramen rotundum. So they are foramen already in these two fossas, and just above is the cranial cavity. So if you leave the disease there, you can imagine that this is going to go within weeks into the cranial cavity. And I already told you, once in the cranial cavity, chances of survival becomes very bleak. That's why MRI is of paramount importance in sinusitis also, not only orbit, also sinusitis. Don't forget that, right? And of course, like I said, because orbit and brain are only soft tissue, and you want to see the nerves and the brain tissue, so MRI is always preferred for soft tissue lesions. We know this. And now comes the thing that tissue, that black necrotic tissue, is mucormycosis. Could be something like there's a disease called T-cell lymphoma. Midline is a disease called T-cell midline lymphoma, which looks very similar, and it's a lymphoma actually. And so there comes the role of biopsy, that you have to confirm that. And MRI along with biopsy are I'll say the two important investigations. They will cleanse the diagnosis of mucormycosis. Of course, we have to go for staining and all that. Already Dr. Sushant has talked about that. So that's about it. So these are the investigations. So I'll say that endoscopy, the first thing is high index of suspicion. Very important in all these patients, high-risk patients. Endoscopic examination. We discussed that weekly, which is not possible, but still as much as you can do. MRI, gadolinium enhanced MRI, and then when you suspect, you have to go for a biopsy and confirm that. So this is what you have to do. This is the key.
Next, the treatment.
Treatment. Now, this is what it boils down to ultimately. This is what we have to do. Now, it goes without saying that you have to control the diabetes. Whatever it takes, you have to control the diabetes. If you cannot control the diabetes, the sugar level, you can be sure that you are not going to be able to treat this disease. That's one thing. And of course, steroid, if the patient is on steroid, long term especially, then you have to also maybe stop steroid, or you have to decrease the quantity or the the duration of steroid, whatever. So for this, you have to sit down with the physician who is treating this patient, and that's why it's a multidisciplinary treatment. One person cannot treat this. You have to sit down as a team and approach this disease like a team. The physician, the ENT guy, the ophthalmologist, everybody comes into play when it comes to treatment. Because sometimes steroid is more important than orbit, or you might have to sacrifice the orbit in order to save the life of the patient. If the lungs are very bad, then of course, if your physician says the steroids cannot be stopped or we cannot decrease the quantity of steroid, then you have to cover that, and you should be prepared to sacrifice the orbit in that case. So steroid. Now what has happened now is, see, if you remember in the first wave, steroid was not the first line of treatment. Steroid only was introduced when the patient became very sick, when the patient went to the ICU and the saturation started falling. That's when the steroid was introduced. But this time, second wave, if you know, because the cases are so many and so many fatalities, that first line, steroid has become the first line of treatment. And most of these patients, this is the first line of treatment, and it continues beyond. Once your report has come negative, all other drugs you have stopped, but the steroid continues because you have seen relapses, sudden relapses, and the lungs just give away. And that can only be prevented by steroid. So patients, they start with steroid and continue the steroid for 3 weeks, 4 weeks, 5 weeks. And this is the main reason why mucormycosis suddenly becomes such an important disease now, because of this one practice where you start with steroid and continue to go weeks and weeks and weeks and weeks. And that's why this treatment of steroid, you have to really be very sensitive about this fact and discuss with the physician whether the steroid can be continued. Now these two are almost like a preventive step. What is the main thing as a treatment? The most important drug is amphotericin B. Lysosomal amphotericin B is the most important drug. It's very effective in mucormycosis. The only effective drug you can say is this amphotericin B, right? And I told you that a lot of patients are waiting for surgeries. And so straight away, this is the first thing. The moment you suspect, even if you suspect mucormycosis, just start on this amphotericin B straight away. Now the problem with this is, it is nephrotoxic. That's the only problem. It's a nephrotoxic drug. And that's why you have to be careful about this. People who have kidney disease or CRF, chronic renal failures, in this patient you cannot give. And for the same reason, you cannot continue for a long duration of time. If you have to continue for a long duration of time, then try to shift to other and less toxic antifungal. We'll talk about that. Now, why lysosomal?
Sir, how expensive? Sir, I'll slightly interrupt you on this. How expensive is it? Because
it's very, very.
It is
very expensive.
Sir, I got the estimates of around 60 to 70,000 per week therapy. I mean,
yeah. Every day, each day is 7 to 10,000.
7 to 10K per day or 70K per week. It is expensive.
Yeah. So that's the problem. It's very, and all these antifungals are very expensive. All of them.
Okay.
Now, why lysosomal? Lysosomal for two reasons. A, it penetrates the pathogen very nicely, and B, it is more effective. It's very effective, lysosomal. And the toxicity is less compared to rest of the amphotericin B. The dose is important. You have to know the dose of this amphotericin B. It's less than 5 milligram per kg per day. That's in a normal, like only sinuses are involved, nose and sinuses are involved. Then less than 5 milligram per kg per day. But once induced in the orbit, then you have to increase maybe beyond 5 milligram per day, between anything from 5 to 10 milligram per day, depending on the situation, for patients whose orbital involvement has happened. But once it goes to the cranial cavity, you have to give 10 milligram per kg orbit per day. So 5 normally, 5 to 10 orbit, and 10 for cranial spread. So this dose is very, very important. If they ask about this drug, they are going to talk about dose, I'm sure, right? Now, we have other antifungal. As you can see, there are two more. One is posaconazole, and below that is isavuconazole. These are two azoles. These are relatively newer drugs, and they can be given in IV format as well as tablet formats. There are two indications for these two drugs. A, where amphotericin B cannot be given for whatever reasons. Usually, as I said, people who are on kidney diseases, they cannot be given amphotericin B, and in those two patients, you have to go for one of these two azoles. And the second indication is if you have to continue amphotericin B for a long duration of time, again, because it's a very toxic drug, so after giving it for 2 weeks, maybe 3 weeks, then we shift on to this less toxic drugs. This posaconazole and isavuconazole, they may not be as effective as amphotericin B for mucormycosis, but they are definitely less toxic, and that's why we prefer them. And these two drugs are relatively new, and so we don't have a complete information about these drugs. We are still, we are still finding out of these drugs. So we are slightly hesitant of a drug that we don't know too much about. But they are costly drugs. They may be costlier than amphotericin B. So cost is again a huge factor here. So all the antifungals, these antifungals are very, very costly. Now this is the medicinal part. The second thing, in addition to this, you have to do is surgical debridement of the necrosed tissue. You have to remove the tissue that is involved. So you have to do endoscopic FES, as you can see, functional endoscopic sinus surgery. Every patient of mucormycosis will have to undergo functional endoscopic sinus surgery and remove all the involved tissue. I'll tell you something about this here. Whenever we do functional endoscopic sinus surgery for any disease, sinusitis or polyps or any other disease, what we often say is we underdo the surgery. Underdo means we do less than what is required. Because as we discussed, nasal cavity lies in a very critical area. Just lateral is the orbit with so many vessels and nerves. Just above is the cranial cavity. And therefore, we don't want to cause any complication. So when in doubt, leave it. When in doubt, leave it, just underdo. This is the only disease, please note, mucormycosis is the only condition where you do FES and you overdo. You do more than what is required. That means when in doubt, remove it. You can't leave any tissue behind, because that simple small tissue that you left behind, you don't know where it's going to go tomorrow. And we all know the two areas it can go to, this orbit and the cranial cavity. And then what it can do, we have already discussed about that. So FES is overdone in this case. And when you go for follow-up, the patient comes for follow-up again and again, and again you do endoscopic examination on follow-up, and if you feel that the tissue has been left behind or something is not doubtful there, you repeat the surgery and remove the tissue. Suppose today you've done the surgery and day after tomorrow you do follow-up endoscopic examination and you find there is a tissue which is doubtful, you think maybe this is a positive tissue. What do? You don't give antifungal and wait and all that. You remove that tissue again, second surgery. Third day again you find there is a tissue left, again you do a surgery. You understand what I mean? So the approach is very, very aggressive, right? And the fourth thing is that if the orbit is involved, if there is any evidence of orbital involvement, either the patient has ophthalmoplegia, diplopia, that is loss of vision, or even MRI findings suggestive of orbital spread, then you have to do orbital exenteration. Look at the second last line, orbital exenteration, where you have to remove the orbit. Now before the COVID started, it was a blanket statement. Orbital involvement by mucormycosis, remove the orbit. That was a dictum. But now that so many patients are coming with orbital involvement, I know of a patient who had both the eyes blind. Of course, in this patient you have to remove the orbit, but people who have minimal involvement of the orbit, little bit of ophthalmoplegia maybe, most of the tissue is already normal. So you can't sacrifice the eye easily. Eye is such a vital organ. So what we have done is, if you see, very minimal debridement, or as we call it, orbital decompression. Look at the last one. We are doing a lot of orbital decompression and use a lot of antifungal locally also. We are using antifungal locally also. So next slide, Dr. Sushant.
Yes, sir. Before we go further, actually, there were 2-3 queries. Sir,
Okay.
we will be discussing, somebody had talked about Divesh, you talked about role of prophylaxis. We'll be discussing that
Yes, prophylaxis
ICMR,
we'll talk about.
I'll,
Definitely.
ICMR actually does not say as of now that mucormycosis prophylaxis has to be given. But sir, if I'm right, the Western guidelines are saying that posaconazole can be given as prophylaxis in high-risk
Yeah.
patients in the West.
Yeah. I think Lancet says that.
Lancet says that, sir, that in Western countries they are giving posaconazole 200 units per day TDS as prophylaxis,
Mhm.
but ICMR is not in favor of prophylaxis at present.
Yeah.
That
Yeah.
was for you, Bache. Divesh. Sir, Tushar has a doubt.
What is it?
Tushar, actually, it's concerning him, so
Okay. He says, I also have symptoms of sinusitis for 2 days, and previously I had this symptom for 10 days. before, as you are still COVID positive. Are you still COVID positive and taking steroid? So if you are COVID positive and you are on steroid, then you should definitely get an endoscopy done.
Okay. Next,
If you're not taking steroid, then
no problem.
then you don't should not bother.
So,
Like we discussed already, that in patients where we either do not want to continue amphotericin B or we cannot give amphotericin B, then we have option of posaconazole, as we have discussed already, which is also, according to some books, can be used as a prophylactic drug. And isavuconazole is a maintenance drug. That's what I said. It's a maintenance drug because once you complete the course of amphotericin B, and you feel that you still need to continue with the antifungal, then we shift on to this one. And also for patients with kidney disease, this one we have discussed. Now look at the third line, orbital exenteration we have discussed, and below that is orbital decompression. This is what I was talking about, that this is a minimal compression of the orbit, it's a minimal surgery of the orbit. The idea is to preserve the orbit, but in these cases, you have to use local antifungal gels. We have local gels of amphotericin B, so we implant into the orbital cavity and hope that it acts. Now we don't have sufficient data to know whether it is effective or not, but you should know that there is a local gel of amphotericin B also, which is very commonly nowadays in this scenario used for orbit where you have not done the exenteration. If you go for the exenteration, then you don't need it. Only when you have done minimal surgery or decompression in those patients. And last thing in treatment is hyperbaric oxygen. Now, hyperbaric oxygen is useful for any disease where there is ischemia because it will increase the oxygen. The blood flow is less, but the oxygen concentration in the blood is more. That's how it helps. So it takes care of the ischemia part. And we already know that one of the things this disease does is ischemia because of the angio-invasive nature. And that's why hyperbaric oxygen is a very, very useful thing. So this is important. So coming, if in a nutshell, if I say 5 things about this treatment, you have to control sugar and maybe stop steroid if it's possible. Amphotericin B or any other fungal, very, very important. FES, functional, and these are the must. Anti-diabetic, steroids, amphotericin B, and FES surgery, debridement. This is must. For orbital spread, you have to do exenteration, and additionally, you can go for hyperbaric oxygen. So this is your treatment. And those are amphotericin B, very, very important.
True. Done, sir.
And prevention, of course, as we said, we have to control sugar, be careful about steroids. And this, a lot of people who go to the ICUs and they get intubated and they use oxygen. So because they are used from person to person, sometimes get transmitted from one person to the other person. So when we use these gadgets, appliances, you have to be careful that you clean them before you use from one patient to the other patient. So that's very, very important.
Somebody had asked about bedside cleanliness, but clean and sterilized appliances will certainly reduce the risk of mucormycosis.
Yeah.
Next, as Bache JS, this is for you. Some doctors are starting steroids in mild COVID. Bache, thing is that if even in cases of mild COVID, what has been seen at least in the daily setup is if the CRP is more than 100, that is an indication of cytokine storm. So some clinicians are starting steroids in case of mild COVID to prevent inflammatory or the cytokine storm, because once cytokine storm sets in, there is rapid reduction in PO2 levels. So suppose there is a patient with a very high CRP is more than 100, but his PO2 levels and respiratory rate is maintained. Mild COVID means PO2 and respiratory rate is maintained, but if the CRP is very high, that is an indication for starting steroids at present. So that
one more point. Or CRP is rising steadily. Not reach 100, but still rising every day.
True.
So that's another.
That is another indication. So that is why the risk of mucormycosis is extremely high. But those doctors are not going against the protocol. They are following the protocol of treatment of COVID only. Sir, I guess absolutely done. Sir,
there's one doubt, I think. Is surgery required for nasal cases also?
Okay.
As I said, if there is evidence of mucormycosis confirmed, you have to remove the tissue. But it's very clear. If there is evidence of mucormycosis, you have to surgically remove that tissue. It's as simple as that.
Done. So I guess, sir, this it was a pretty informative session, no doubt. And for all the students, bache, please do leave the comments in the comment box how you liked the session, do like the video, and do tell us. We'll look forward to your feedbacks. For the juniors as well as for those who will be giving NEET PG, but on the plus subscription, I guess you guys know this pretty well that we are doing 3 seasons. Season 1 will be the case based high yield topics. Season 2 will be the subject wise test, that is the test and the image based revision, and season 3 the MCQs, the test and analysis for your complete preparation. You can use the code PathoUA for discounts. Needless to say, be safe. I mean, no doubt about it, Vijay, and bestest of luck from both of us sides. So,
Thank you, guys.
and
Best of
sir,
luck.
really thanks. I mean, for doing the joint session, and it actually increased my knowledge about the endoscopic procedures, the FIS, and I knew it is a severe disease, but this session is actually an eye opener. I mean, you really helped that way to tell us about the severity. Thank you, sir, for the same.
I hope it helps the students as well.
Done. Take care, sir. Thank you, and take care.
Thank you.
Take care.